I think we are running an hour late. As we can see, there is a big passion among the debaters, and we had two teams arguing with each other. So I will try to rush it through, and then we will have a break, small break after this, rather than have a break after the session. So if I move forward, first of all, I need to acknowledge Mr. Lin, who is not here with us today because his wife has gone to labor overnight. So he has apologized to come in. So he was supposed to be here today. So I will remove that. Obviously, we have heard sleep is the most common. I will not go through the advantages as we need to rush through. I'm just going to deal with how we avoid complications in Homerton. As you have heard from Kalpana, we have very low risk of complications in this hospital. We don't know why, but we do have some tricks which we do routinely for all patients. So we're going to touch upon hemorrhage, leak, stenosis, and reflux. Hemorrhage incidence in the literature is up to 6%, though there has been some old studies showing up to 16%. Sources could be inside the lumen or it could be outside the lumen. Technical factors, obviously we know surgical techniques. We have two different staplers. One bleeds more than the other. I'm sure we are all aware, if we use a black, they bleed more. If we use green, less, and blue or white bleeds less. Length of tissue compression, standard is 20 seconds, though some people can do up to 2 minutes. Stable and reinforcement, I think we have discussed this before. I will just go through briefly overseeing or buttressing or none. Obviously, we in Homerton do no reinforcement at all. Leak, I'm just going to look at again, similar percentage, 1 to 6%, though recent case series, as we have gained increase, as what Kalpana has said, that less experience is less than 1%. 90% happen at the top end of the stomach. It is a high pressure system and it's a compromised vascular supply. Surgical technique, that's where my thing will come in the end. Size of the bougie, what size we use, 30, 32, 34, 36, or 40 French or even higher bougie, and reinforcement that can prevent a leak. So I will not go through these things, but there are three reinforcements, either stitches or running sutures. The least costly, again, the studies are not showing that overseeing the staple line during sleeve gastrectomy does not decrease the risk. If you look at this, does not reduce the incidence of bleeding as well. Buttressing, I will skip through these slides. I think we have gone through the burst pressure as well. I will just go through three meta-analyses. This one, I think one of my colleagues did so no benefit of buttressing. If you look at another study, they showed leak rate in sleeve was significantly lower using absorbable buttressing rather than overseeing bovine strips or no reinforcement. So there is conflicting results. Again, this meta-analysis showed staple line reinforcement significantly reduce the likelihood of staple line leakage with a biologic mattress. I think Kalpana has showed this one, that in fact that study showed a higher leak rate, though they did show lower bleed rates. Again, hemorrhage, what's the incidence of buttressing and hemorrhage? Definitely, I think there is general tendency that reinforcement does reduce bleeding generally. So if we go with what we said earlier on, several studies have confirmed that reinforcement reduces intraoperative bleeding, as we have agreed, but the difference is not significant. It's hardly less than 100 mL. The question is it worth spending 1,000 euros or in dollars or in pounds to reduce that bleeding? For staple line leakage, while there is some evidence to show that reinforcement reduces staple line leak, but proving that this intervention decreases leakage is extremely challenging. And the reason is that the leak rate is so low that powering a study is very difficult. However, there is an argument, which I think Sanjay did put it through, that the cost of a leak can be very high in terms of treating its complications. Therefore, the additional cost for the use of buttressing may be justified. But I will leave that decision to yourselves. Bougie side, there is some, I think, agreement among all of this that we should use a higher size bougie. With this meta-analysis showing bougie more than 40 French does reduce a leak. And another studies, this MBSAQIP study did show the same thing. 38 bougie or higher does significantly reduce leak rate. So I think there is generally agreement that the higher the bougie, the less the chances of a leak. Sleeve stenosis is one cause of a leak, usually at the level incisura, which I think is the most important thing to prevent a leak. And sometimes we don't place the bougie while stapling the incisura, and that should not happen. Functional stenosis is something, again, which we can avoid. I will not go to the types. One is a localized twist, one is a spiral course through the whole lumen of the sleeve. Reflux, we have just heard the debate. It's multifactorial, it's controversial. But hiatus hernia is a risk factor which is very common, and as my colleague has said, we should be repairing it. But let's see. So my experience has been there for the last 9-10 years since I've been here in this hospital. This is an old study, finished in February this year, 400 patients. Middle age, 43 years, predominantly females, BMI ranging from 32 to 82, with the average BMI of 47, ASA graded 2, and OSMRS of B. I had almost a total of 15 complications. That includes readmissions and reoperations, so making a percentage of 3.72%. If you look at bleeding, I just had 2 patients with bleed, which required laparoscopy and was out. There was some drop in hemoglobin, some more patients, but we didn't look into that because there was probably hemodilution. If you look at staple line leak, I have been lucky so far. I may have a leak next week, but I haven't had a leak so far. Just like Sanjay said, he didn't have a leak. However, we had one patient who had a thermal injury, and that's the only patient which we did in my 400 with an energized student with a bipolar. I don't want to name the company because they are here, but with a bipolar component. And that does, because both the blades are hot, they do cause damage if you're not careful. Probably it's a learning curve. I used that one single, the trust wanted to use that instrument for us because it's cheaper to them, and we used it, and that caused a leak in the posterior wall of the fundus. Chest infection, I had 4 infections in my last 10 years. 2 patients came back with abdominal pain, and we did a diagnostic laparoscopy. They were both normal. 4 patients had dysphagia, but again, normal investigation. They went home the next day, and 1 patient had chest pain with a normal echocardiogram post-op. We haven't had any conversion to open surgery. We had no inpatient deaths. Just like one slide of classification between minor and major with Cleveland-Dindo, 10 with minor and 5 with major, but we have all described before already. So why do we have such a low list in Homerton? Probably standardization is what I feel is the best. And we have discussed that before. Standardization is the technique, is the key. Everyone who is doing the fellow, trainee, surgeon should do the same step every time again and again. What do we do to avoid hemorrhage? One thing which I have learned early on, what I feel that I will just go through the bleeding. Bleeding is when most of the bleed we have noticed is from the greater curve arcade, the right and left gastroepiploic. And what we do, or what I do at least, we put lots of bleeding or lots of, through the energized instruments, we interrupt the arcade throughout from the top to the bottom. And I feel that does reduce the bleeding, or maybe that's the reason why we have less bleeding. I'm sure most of us do a hemostatic test. We raise the blood pressure at the end of the operation before the patient extubated up to 140 millimeter mercury, and that does see any staple line bleed, and that we can put extra clips on what I call as a hedgehog clip. Now, some of my colleagues may not like it. If we have to go back to do a bypass, you have to remove 1 or 2 of these clips where you're going to staple it. But this does reduce the bleed, especially the smaller bleeds, which just causes a drop in hemoglobin, but not really laparoscopy. Avoidance of leak, the tips, we must use standardized selection of cases from the top to the bottom. Most importantly, we should not angulate in the first 2 stapler firing, but that's the way the incisura comes. Final stapling has to be 1 centimeter away from the OG junction. We should all do methylene blue dye leak test because it's a very small leak, but you can see, and that will avoid you coming back the next day or the first night after surgery. Selection, I always use the first firing as a black. The second and third is usually purple, but it can vary depending on the thickness or the male or a female patient. And all the subsequent firings are either gold or tan, depending on which company staplers you're using it. Gastric stenosis, as I said, we should use the first and second stapler, keep it straight, and that will reduce. And that does mean losing 1 stapler or wasting 1 stapler, because the second stapler you end up not using the whole length. You have to crossfire across that first stapler. But that does reduce the stricture. Every successive staple firing should be performed along the same staple line. Equilateral, that's what will avoid functional stenosis. The assistant on the left side must hold the stomach, and lateral traction has to be along the greater curvature, so there is no anterior or posterior wall pull by the assistant. And there should be avoiding excessive lateral traction, otherwise that will cause narrowing of the stomach as well. Reflux, I think already said, we must look into the hiatus. Even if it's a small dimple, we must dissect circumferentially the anterior, right and left crura and fix it. But if there is a big hiatus hernia or a moderate side, we should not hesitate either to a bypass if the patient is consented, or just abandon the operation. We should not just proceed and do so because they will have reflux post-op. We should carefully dissect the angle of his, maintaining safe distance from geo junction, but we shouldn't avoid the sling fibers to avoid a reflux. And the regular sleep, again, mid-stomach stenosis is the most important thing to avoid reflux as well. Complete fundus mobilization, as we have said, is very important. Methylene blue light, I think, should be done for every patient. I think that's very difficult. I do medical legal reports, and I see if there's no one, somebody has not done methylene blue light test, that something goes against that report. I normally use drain for every patient from the last 10 years. And that I learned from Dr. Dilemans when I was there with him. He used to put drains for every patient, whether it was a bypass or a sleeve, and I have just carry on with that. Though I was with Dr. Mr. Taunton, but he never used to put a drain there. I never used triple A reinforcement in my life, and I don't think I will restart even if Sanjay wants to convince me. And definitely caution, avoid bipolar unless you are really trained for it. Sorry, we've gone. One other thing, we do have a very consistent post-operative protocol for all patients. And we say 3 weeks of free fluids with straw. We normally emphasize straw for 3 weeks. And that's something which I think gives the patient in their head that you must drink and not take anything. Because it's very easy to gulp things. And if you gulp things, then you will have a leak because there could be a higher burst pressure inside. And we call it everything. There's some urophagia, but that can be tackled in the first few weeks. After 3 weeks, the next 2 weeks will be puri diet, and the next 2 weeks will be semi-solid, and the last 2 weeks will be solid. We again follow 5P criteria for discharge for the trainees, because that just helps them, and they will not ring me. Pain, there's no pain except paracetamol. Pulse is less than 90. Because I put a drain so that the drain is hemoserous. That's fine. Amount is not relevant. Is the color blue or green? Blue is the dye, green is the bile. CRP must be falling at least less than 100. And they have passed flatus. If the flatus is there, that means they don't have a leak because they will have either collection or nothing. So, great attention to detail. That's for the trainees here who are here, not for the big surgeons. Meticulous surgical technique is very important to avoid, and standardization is the key. I'm afraid if you do the same thing for every patient, you will not have a problem with the sleeve. Thank you very much.
Any questions, burning questions? Jack?
Okay, thanks for an excellent talk. You said that you need to end your staple line 1 centimeter from the G junction. But in many male patients, there's a lot of fat there. And how do you measure that? Do you dissect the fat off in everybody?
I think you're right, Jack. I think in a male patient, it's very difficult. And I try not to dissect the cardiac of fat unless it's very big encroaching. Then I will just reflect it. Otherwise, I'll just go lateral to the cardiac of fat. But because the cardiac of fat is very important in the vascular supply, I think there is a tiny blood vessels keeps the blood supply that docks here. I think we should avoid dissecting the cardiac of fat, at least anteriorly. Posteriorly, we must dissect everything to avoid a fundus there. Rui.
Great talk. I didn't understand. If you visualize someone first, you cut the short vessel first and bring the stomach later. Is it important for anything?
I do both ways. I keep it very pragmatic. If in a male patient, it's very difficult to go all the way lateral to the top. So what I do halfway and then go medially, staple it, and then tackle the top short gastric in the end once we have divided the whole stomach. Okay. So I keep it both ways because if you do try to do the whole posterior laterally first at the end, you will end up with a hematoma on the top short gastric, especially in a male patient. So I do mixed. I do both depending on the patient.
When you remove the pouch of the gastric stomach, you are going to have more easy to have some undulations and some torsion.
Yeah.
Sanjay, can we ask how many people dissected the fat pad the time of sleeve gastrectomy in the audience? How many people do not dissect?
Sanjay, yeah.
Sanjay, I totally agree with you about standardization, and I don't know how many surgeons would be willing to do this in the audience, but we've started to try and measure that. digitally with all the laparoscopic videos. So how are you at Homerton checking that your standardization is true? Do you look back on the video data? Do you look at any radiology, endoscopy? How do you know that your sleeves are truly standardized? Because I think you're onto a winner here, and we're trying to look into this, but how do you prove that your sleeves are actually standardized across all of your colleagues?
What I can say, we don't record sleeves, at least not in my list. But I'm always there when the trainee is there. I just hold the camera or sit there behind him, and I doesn't let him do anything unless it's what I do in the same steps every time. And they know immediately in the first week or two when they come back to us that that's the way we have to do it. Yeah.
If you or anyone else is interested, we are starting part of a massive multi-center study. If anyone is routinely recording their sleeve gastrectomies, bypasses, minis, revisions, and you want it to be analyzed by machine learning and AI, please drop me a line.
That would be a great thing. I think there's a stalls as well, I understand.
Thank you, Sanjay. A very nice presentation. Now, with regards to the blue dye test, with the leak test, have you ever seen a leak? I don't know how many of the surgeons in this audience do a blue dye test on a regular basis, on routine basis on their sleeves.
Majority.
Have you ever seen a leak? Have you in these 4?
Not in my experience, no. But I still do it, and I still keep doing it. So that's one thing which I don't want to come back the same night or the next night just because there is a staple line somewhere leak. But the blue dye test will tell you straight away if there's a technical fault at the time of stapling for a leak. Obviously, there can be ischemic cause of a leak, which can develop 5 days later, but that won't be because of you missed it on the first night or the first day.
Thank you.
Sanjay, you have slept well for over 400 patients.
So far, thank you.
400. I mean, if this was an audit, if, this is a terrific audit, you should stop doing the leak test and you should stop leaving drains. They have not helped your clinical management in one single case.
That's it. Jury is still out. Okay.
With that test, you can check the shape of the pouch and the pressure.
Yeah, that's a good point. We can see the sleeve, how does it look like. So that is not
I agree with Bruno.
And
Thanks for the fantastic details you shared with us. I think the leak test, I agree with you. I think it's important from a medical legal perspective to make sure you don't have a device failure or you didn't make a hole somewhere with your ultrasonic device. With such a low rate of leaks and bleedings, I think you can ditch the drain. Save money, ditch the drain.
Yeah, Sanjay, there are many colleagues amongst the audience who are doing the cardiac dissection of the cardiac pad of fats, and there are many who are not doing. What's your impression about doing and not doing that?
I think it's very important, to don't leave any fundus behind if you don't dissect it as in the very obese patient. If you don't do that, you are leaving there some fundus. I think it's mandatory to do that, except if the patient is too lean, then probably they don't deserve bariatric surgery. Where the patient is obese patient, you have a fat pad there, you have to leave it out. In terms of be sure that you don't leave any fundus behind you.
that's why everybody important dissect posteriorly.
Not anteriorly.
Anteriorly as well.
Anteriorly. You can see this centimeter that Jack asked you. If you leave it out.
Not 3 centimeters, probably a centimeter of
And you can use this fat for performing the
Cover.
statistical reinforcement by hands-on. Like a patch. I think it's going to be advisable for not leaving behind more than 1 centimeter.
Yeah.
To remove as much fundus as you can.
Sanjay, how important do you think it is not to cross staple lines on your sleeve? Firing each staple.
Yeah, I don't think they do fire on the top of each other. So I don't think there's a problem with firing. Even if they go across it, I don't think it will fire. Are you worried about the misfire?
In terms of leak.
Problem is if you don't cross it, then there is a risk you may have a leak between the two staple lines, between the two cartridges.
So you don't think it matters if you just is some evidence that if you're going to cross them, you should go 90 degrees to it,
Okay.
which is the stuff that we saw from Austria. Okay. So the question is, does it matter?
But you're crossing only at the incisura. You're not crossing on the top.
No, we're not crossing.
Not crossing.
What is
That's
the
the-
exact
that's
what
the
is the
point.
exact size of the bougie, Sanjay, you are using in your cases of these 400 cases you have done?
In my trust, we have only 30 French bougie. We have recently have 34 now, but we haven't have 38 or 40. So I have been still using 30 or 34. 90% of my cases have been done with 30 bougies. But I think that post of 3 weeks with a straw is the most important thing with the 30 bougie. You must be very strict, otherwise it will be very difficult.
Sanjay,
You're not snug.
We are not snug, no. I definitely believe it will become 40, I suspect, if we measure it. But we're definitely not very snug on the bougie. I'm using 30% bougie.
Sanjay, I was quite interested with your post-op diet protocol using the straw and liquids for 3 weeks. Have you done any? Is there any data on that, or is
No,
that?
there's no data, but we have been using in Homerton since I joined 10 years ago, and it has been working for us. So we, as I said, we haven't had except one patient for my colleague. So I think we continue to use that. And that's universal for among all of us. Though the technique may vary within my colleagues, but that thing is definitely we all do 3 weeks for liquids for everybody.
And the other thing is, there's a lot of interest in using tranexamic acid perioperatively in bariatric surgery patients. There's a few publications that are out. Our unit is about to release a big study. When I worked in Liverpool with David Kerrigan, have you had any experience in using it perioperatively for those patients who have an HB drop, which sometimes you label as hemodilution? Do you think it has? Do you think it has a role?
I've read through the reports on the studies, but we have never used it.
We have. And that's
Rachel is going to say something.
Sanjay, I've got one question for you, and it's a very light-hearted question. I'm now the third generation in this training lineage. So you trained me, and you've been through the hands of Dr. Himpens and Mr. Wellborn. So just thinking about how practice changes through the generations, as it were. Those other two gentlemen, do they still use drains with their sleeves?
I think Dr. Dilemmas, I'm sure he still uses the drains, because that's where I learned that drain thing.
Now, I sometimes have the perception that some surgeons think that they are better than somebody else by not leaving a drain. So, on itself, it's not an argument. Just as something as a safety precaution in operating high volumes, so at 10 o'clock in the evening, one of my residents had to see all the patients, then we have more or less an estimate if something goes wrong or not. It's not 100%
Accurate.
sure, but anyway, that's a bit still the way we work. And also when it gets to bypass, we leave that drain until the morning, day after surgery. It's more a conservative approach, but it's not going to hurt your patient. And we feel ourselves a bit,
I think it just gives a false reassurance, but it gives a reassurance. So to trainee, there's no blue color because the methylene blue or a bile kind of got in the drain.
The other view. The other view is that bariatric surgery, modern bariatric surgery is done according to ERAS technique and approach, enhanced recovery after surgery. No nasogastric tube, no brain, no urine scattering. Patient sit up in the floor 3 to 4 hours after surgery, start drinking water. This is the beauty. I am old as Bruno and Jacques, and I totally changed because I think that without putting the drain, management of leak is much better. I think that when the patient goes home and you go to the leak, you might have a leak that is delayed because it's mostly self-contained. If you have a drainage, 90% that drainage is going to be part of your cutaneous peritoneal tract fistula. So I think that the patient goes home much quicker without drain, develop a leaks. Most of the time you are going to see it and self-contained and it's not the peritoneal spreading leak. So I think it's much better to not leak.
Thank you, Luigi.
Thank you for the question. I've never used a drain for a sleeve, but I always do what Bruno tells me to do. So if he says I will, I should, I will.
Please.
color cartridges are not standardized in any surgeon's hands. So you're saying that doesn't matter what color you use. I know there is science behind staple height and leaks and bleeding, but every surgeon I've seen uses a different color.
Absolutely. I think
So
that's
not standardized.
yeah. I don't think there's a standardized sleeve cartridge for which one to use, but that's what I use for the last 400 cases. But that I may be wrong. Maybe you have a different color use, and that will continue to get better.
Can we conclude that the type of cartridge actually doesn't have much effect because the leak rates are not different for different surgeons overall, but everyone is using different cartridges? I think we need to stop at this point. Really.
Shall we go ahead or shall we take a break, Sanjay?
Yes,
in Oxford we can't have it. Your chair, your moderate, your chair and chat, day 2. Yeah?
I agree, there's no consensus on the size of the type of the color of the cartridge you use, but generally green and tan are being accepted. Green is what we use. However, having looked at the medical legal side, if you use a blue cartridge or anything and there's a leak, you know no leaks to stand in this country. The lawyers will definitely get you. So tan, green is up to you, some size. There's no standardization, but never go for blue.
Essentially not. But we'll talk about it over coffee.
You try something.